Okay, we are now live. So hi, my name is Izzy. I'm the psych lead for Mind the Bleep, and I'm joined today by Dr. Anya Borissova, who's going to take us through the Mental Health Act. So thank you very much, Anya, for offering to take this session for us.
Brilliant. Thanks so much, Izzy. Hi, everyone. So I'm Anya. I'm a psychiatry trainee in South London at the moment, and I help co-host a podcast that you can see pictured here, and we're running this series on psychiatry teaching with Izzy, which hopefully some of you have been to previous sessions, and hopefully we'll see you at future ones as well. So the information that I'll be sharing today is specifically legally correct in England and Wales. So I'm going to leave this up as I introduce the session, but if people want to share where they work or study, if they're medical, nursing, any other health professions, just so I start to get an idea of who's in the room and can try and tailor some of the information that I shared to that. But in terms of the legal information, as I say, it will be around the Mental Health Act in England and Wales, because that's what I use and have been trained in. Some of that may well be relevant in Scotland or other parts of the country. Some of the principles may be relevant, in other parts of the world. Some of the principles may be relevant in other parts of the world as well, but every country will have their own way of managing the legal side of mental health. So if you work somewhere else, unfortunately, you won't be able to take this forward directly into your practice, but it may give you some pointers as to what kind of how to think about some of these issues. I'm not seeing anything in the chat, but if people are, that may just be me. So Izzy, shout up if you are seeing things in the chat. If people are able to use the chat and are up to sharing who and where they are, please do, but not to worry if not. I will try and keep things a little bit interactive. So again, feel free to pitch in with opinions or ideas. I may not be able to pick out everything that's posted, but I'll try and comment on things as we go. And if people have questions, I'm joining from London. So I work in South London and live in London, in England. Very nice to meet you, Sue. So let me make a start. So the way that I'm going to run this is just follow the journey of a case, which is not it's actually not unusual for somebody to go through all the steps of the main parts of the Mental Health Act through their journey in Psychiatric Services. My hope is that you will understand the differences between the main parts of the Mental Health Act that you might encounter in routine clinical practice. There are other sections and other parts that are used commonly in specialist parts of psychiatry, but less commonly, I think, just in general hospitals. So I'm trying to keep it fairly contained and reasonably straightforward. But obviously, if you're looking for more detailed information, I'll have some resources at the end where you can go to look that up. And I'll talk briefly about some of the problems with the Mental Health Act as well, because it has just recently undergone a review and it may well be changing in coming years. Some terminology just to introduce, and if people feel up to sharing, if they know what these things are already, feel free to post that in the chat. In particular, if anyone knows what an AMP is already without me saying, that's probably the key one to make sure that you know as I start the slides, because actually all of the others I will be talking through as we go. Section 136 is a police-used section, and so that's one that will be applied to people in the community. A Section 5.2, a Section 2 and a Section 3 are all other sections of the Mental Health Act that relate to people who are inpatients in hospitals. And an AMP is an allied mental health professional, very commonly a social worker, sometimes will be a mental health nurse, but what they will definitely not be is a doctor. And they are the person that is in practice, at least really the person that handles the Mental Health Act for patients. So they are the ones who will make an application to use the Mental Health Act if a patient requires it. They are the person that will coordinate the Mental Health Act team. They are the person who will liaise, or who is most responsible for liaising with relatives in certain parts of the Mental Health Act. They tend to be the person who explains the most to the patient, although that's not just a role that is limited to them, and certainly should be something that the entire team is involved with. But they are the people who, at least in my practice, I've often seen as being that person that the patient gets quite a lot from. So I will crack on with the case. And as I say, please do post questions or things that you want clarifying as we go. If I cannot answer it, I will try and think of where the answer might be, because I'm not a legal expert, but what I am is a clinician who has worked with the Mental Health Act for several years. So hopefully I can give you an idea of how these things are relevant in clinical practice. So if we start with a case of a 24-year-old lady brought in by police because of disturbed behaviour on a Section 136 to A&E. Obviously, this case is entirely fictional, but the principles are things that have existed in my clinical practice. The police handover that you receive is something like: Ms. Jones was yelling in the street, she was crying, her friends couldn't seem to calm her down. She was saying that she wanted to die, so they called an ambulance. She was confused when we, as the police, arrived. Could she be intoxicated? A question from the police officers as they hand over to you. And so the questions to start with, and that I will talk through, is who can use the powers of a Section 136? What is a Section 136? How long does it last? And terminology that you will hear referred to in context of a Section 136 is place of safety. So again, to try and for us to all be clear and happy on what a place of safety is. Now, before I switch to my next slide, have people got any thoughts, either from their previous clinical practice or just general knowledge of what any of these answers to these questions might be? I will continue with the answers, but I will continue to ask what ideas people already have as we go through the presentation. So feel free to pitch in at any points. So a Section 136 is something that can be used by the police. And the police can use these powers if they think somebody has a mental disorder, if somebody is in a public place, and if they think that somebody needs immediate help. So the things that were relevant in this last case is that this lady was in a public place, so she was in the street. She kept saying that she wanted to die, and her friends weren't able to make a difference to that, and presumably nor were police when they arrived. And she seemed confused, so suggesting to them that there's a need for an immediate and an urgent action. You may also receive details from the police that, there are things like someone was actively demonstrating that they wanted to die or taking actions to harm themselves in some way. Again, that would be a frequent reason for somebody to have a Section 136 applied. You may hear examples like somebody was just acting in a very disturbed way. For instance, they were going into a shop and got into an argument and they couldn't seem to be calmed down, and what they were saying wasn't quite making sense. So there is an extreme disturbance of behavior. So it wouldn't be as simple as somebody seemed a bit upset and that would lead to someone going on a 136. No, it tends to be quite an extreme change in someone's behavior, or a very risky change in their behavior. And what a Section 136 allows the police to do is to take a person to a place of safety where their mental health will be assessed. And the reason that this kind of legal framework is needed is because generally we are all protected and allowed to, within the limits of the law, act and do as we wish. So the police can't just take us from a place and take us to another place. But what this law allows to be done is for police to do just that, because of a concern for somebody's safety and their need for immediate help. A Section 136 lasts for 24 hours, but it can be extended by 12 hours. And the relevance of that to this case is there's this question of intoxication. So if somebody is intoxicated and that is the reason for their change in behavior, and you might find that out at the place of safety, for instance, by measuring alcohol levels, by measuring if there's presence of drugs, by just taking the history from the person and people around them and finding out that, yes, there was some kind of drug or alcohol or something like that being used. Often a disturbance that is caused by that will get better with a bit of time. And so you want to give that person that bit of time before you make a decision about what potentially quite significant treatment will be. So being able to extend the section means that you have more time for potentially things to just get better on their own, so that you can let the person just go home with some kind of appropriate follow-up, rather than continuing into potentially other restrictive practices using further sections of the Mental Health Act. And finally, what is a place of safety? So in theory, lots of different places can be places of safety. So including someone's house, if the person who owns that residence gives permission or agrees to that. Things like care homes, again, technically can be classed as places of safety. But in practice, generally what we mean by that is a hospital-based place of safety. A&E is one common destination. And in certain parts of the country, you will have places of safety that are on a psychiatric site. So they are a unit that is set up very much like a psychiatric ward. It is not classed as an inpatient ward, but it has rooms, it's run by nurses. There is things like medication available to be used. There are ideally things that can provide extra comfort to people. So for instance, there may often be an occupational therapist there who can do activities with people for the hours that they're in the place of safety. Certainly there are a lot of those in London and in some other parts of England. Again, if people are joining from other parts of the UK or other parts of the world, it would be interesting to hear if you have things like that or anything similar, because it would be great to learn how different places handle these kinds of things. In theory, a place of safety could also be a police station, but increasingly it's recognised that this is not an appropriate place for people to receive mental health treatment from. For people under 18, it's called a never event. So somebody who is under 18 should not be taken to a police station on a Section 136. They should always be taken to hospital. And that principle also does apply for people over 18, but it's not quite as strict. Any questions on that point, or any thoughts, sort of reflections that people have, any experiences that people want to share? And again, if anyone's joined a bit late and wants to share what part of the world they work in, what job or studying they do, it would be great to hear where people are at, so I can try and tailor things. So let me move on to some potential clinical type situations that I've encountered. Any thoughts on what might happen if, after being in the hospital for 6 hours, so as in the place of safety for 6 hours, everything seems back to normal with Ms. Jones? She's able to, have a conversation with you, tell you what it was that was going on. She says that she no longer wants to die. She feels okay. She's perhaps not entirely sure what happened to lead to that change in behavior, but actually things seem all right now. Can you just send her home and nothing else in terms of your legal powers? So, the answer is that it depends. So if you are a clinician, so a Section 12 approved doctor who is seeing her. And if Ms. Jones has no prior history of any mental illness, then in theory you could just discharge her without asking the AMP to come and see her. If there is, however, any prior history of mental illness, then you would be, and often the recommendation is you have a discussion with the AMP anyway. And if there is a prior history of mental illness, then the AMP would also need to come and see the patient, and only they would be able to discharge her off the section. What if Ms. Jones speaks to you about how low, how upset she's been feeling and feels that she needs more help? And again, you're able to have a conversation with her about it. It becomes quite clear that it isn't the right option for her to go straight home, but actually she can talk to you about what it is that she needs. Any thoughts on what your legal pathway might be at that point if you're thinking that actually what she needs is more time in hospital, so she needs an admission? But how might you arrange that admission from a legal perspective? Would you need to continue to use the Mental Health Act, or could you do anything different? So this is something that will, yeah, lovely, thanks, Izzy. Exactly. So this is something that we'll come in to discuss in more detail, but absolutely that. So you're potentially thinking about, could we arrange an informal admission for this lady? And the principle that this highlights, and a key principle of the Mental Health Act, is to always be thinking about the least restrictive option. So what is the treatment pathway for this person that involves as few infringements upon their liberty as is possible? So if she can discuss, agree, and has what we call capacity, which again we'll come to discuss, then you may well be thinking about whether an informal admission is the appropriate way to go. Or what if you find that you're in a situation where Ms. Jones continues to be quite distressed? She can't seem to make sense of what is happening. She can't seem to really have a conversation with you that gets you to feeling like she understands what is going on, like she can make a decision about what she would like. What might you be thinking at that point in terms of the legal powers that you might need to employ for an admission? Do people have any thoughts? So again, we'll come to discuss this more, but what this is getting at is that you will likely need to use more powers of the Mental Health Act in order to proceed with an admission at that point. So let's start with the first option. So let's say, for instance, that Ms. Jones needed some medical treatment, so is being admitted to the acute medical unit initially. She has been seen by the psychiatry senior doctor, so the SPR, and she's been seen by the allied mental health professional whilst in A&E. She was discharged from the Section 136 because she had capacity, and she agreed for an informal admission after her medical issues were resolved. So what we're going to discuss now is what an informal or voluntary admission means, and what does this capacity point mean? Again, if people already have thoughts about what they know about capacity, drop them in the chat, or in your minds, if you don't quite feel comfortable for sharing, just start to have a think of what can I remember about what capacity means. So an informal or voluntary admission is something that means that the patient has capacity to understand that they're going to hospital, and they have capacity to agree to treatment for that mental health problem. Some really common misconceptions that I was keen to clarify, and this is again on the basis of work that I've done just in general hospitals, not psychiatric hospitals. There can be this idea that an informal admission means that somehow the person is less sick, that we're just not that worried about them, that we don't think they need to come into hospital as much as somebody who is under a section of the Mental Health Act or who's coming for a formal admission. Sometimes people say, oh, you know, if obviously the professionals aren't that bothered about me, if they were, then they would have sectioned me. Or other health professionals might say, you know, does she even need to come into hospital because it's this voluntary, or it's an informal admission. Informal somehow sounds less important than formal. And it isn't any of those things. What it refers to is this least restrictive principle. So somebody may need to come into hospital just as much as somebody else, but if they can understand and weigh up, communicate the reasons for why they think hospital treatment is the right option for them, and if they can be involved in that decision making, then we try to go that way rather than using the powers of the Mental Health Act. It can obviously mean that somebody is less unwell, in the sense that because that decision-making ability is still there, sometimes it is the case that they are not as unwell as somebody who doesn't have that decision-making ability. But it isn't a given, and it doesn't strictly relate to that. And it certainly doesn't relate to them being less in need of support or less in need of any kind of treatment. I appreciate that it's maybe a slightly nuanced point, so if anyone feels like that doesn't quite make sense or wants to ask questions, please do send them in the chat. But I think it is an important point to take away when you leave here today for your clinical practice. It isn't a question of worth or what somebody deserves. It's really a question of the legal principles that we work off, which is to follow the least restrictive option. And it can be the case that somebody who is able to have the decision-making abilities to follow that least restrictive option might not be as unwell as somebody who can't, but that isn't always true. And next, what is capacity? So capacity is something that comes under the Mental Capacity Act. So it's not part of the Mental Health Act directly. So I won't be talking about it in detail, but the principles are very important to the Mental Health Act. And mental capacity always is related to a specific decision. So if you're asked to assess somebody's capacity, make sure that you know what decision you are assessing that capacity for. And it might be something like the decision to have an admission into hospital, the decision to have a specific kind of treatment, and somebody may have capacity to decide on treatment, say with medication, but they may not have capacity to decide on treatment, say, with something like electroconvulsive therapy, maybe. Somebody may have capacity to decide on being admitted to hospital or being treated at home, but they may not have capacity to make decisions on more complex things like how do they fund the payment for their home, just for example. So it really depends, and it's really important to know when you're going to speak to somebody to ascertain if they have capacity, exactly what it is that you are discussing with them. For that reason, if you're assessing capacity for somebody to have a procedure like, for instance, surgery, it's important that you know exactly what that procedure involves. Similarly, if you're assessing the capacity for a treatment like electroconvulsive therapy, psychiatric medication, that you've got a good working understanding of what those treatments mean. The reason that you need that is that you're going to be assessing somebody's ability to weigh up that decision. So that weighing up means that they can talk through and think through the pros, the cons of what that decision involves. And you need to be able to give them that information. So this isn't a memory test. It's not a knowledge test, but it is somebody's ability to understand the information that you give them and that you give them in a clear way, to retain that information for long enough to make use of it and to use it in the decision making, and then to demonstrate that they can think through the pros and cons and then tell you that decision. Capacity is presumed. So if you work in a general hospital, you may potentially not yet have encountered a situation where you're assessing someone's capacity. Because it is, unless there is a mental disorder of some kind that might be affecting capacity, capacity is presumed. But if there is a mental disorder, and that's a condition of assessing capacity, if there is a mental disorder that could be, or a disorder of the brain that could be affecting someone's capacity, that's when you would go through those steps to make that assessment. Feel free to send through any questions that you have in capacity whilst I move on to the next bit. So, sorry, I've made a slight error on this slide in that you are Miss Jones's nurse on the psychiatric ward, and so you're not changing her fluids, but you are offering her food and drink. So Miss Jones has now arrived onto the psychiatric ward. She says that everything's fine, but actually your assessment as her psychiatric nurse is that you're not that sure. She looks quite flat. She looks like she's been crying. You know that she's come in because things didn't seem good. And she came on a police section in the first place. So you're concerned. Not necessarily a question about what should you do just from a general psychiatric perspective, but what can you legally do to stop Miss Jones from leaving? Any thoughts that anyone has? So, yeah, use holding powers, exactly. So, colloquially known as the nurse's holding power, a psychiatric nurse who, for reasons of safety or otherwise, is unable to get a medical professional to come and see a patient in good time, can use and apply Section 5(4) of the Mental Health Act. So it isn't used very frequently because usually hospital provisions are such that it is possible for nurses to get hold of a doctor to come and review the patient. But of course, there are situations where actually that isn't the case. And a registered psychiatric nurse, or so a nurse for whom their scope of practice is within psychiatry or learning disabilities, can use this section of the Mental Health Act. It enables that patient to be held on the ward for 6 hours. And again, this is what we're talking about legal powers. So usually we are legally allowed to come and go from any environment as we wish. But if there is a significant concern about somebody's safety and that there might be a mental disorder that is affecting their safety, we can employ this power to keep somebody, for instance, on a locked psychiatric ward. Aditola, you ask a very complicated question, which when I was on my Section 12 course, sort of learning all about the use of the Mental Health Act, was a big area of discussion. So I will come back to that at the end, in part because there isn't a straightforward answer, but we can spend a little bit of time thinking and talking about it together. So with a Section 5(4), the person has to be reviewed before the end of that 6 hours time so that an onward decision is made. So moving on to the next point, and maybe actually Attila, your question will fit in too as we talk here. And I will explain, this section will help explain why what you ask is such a complicated question, which I imagine is why you've asked. So you're now the duty doctor in the psychiatric unit and you're called by her nurse. And you very much agree with your colleague that she seems quite low. And to you, as the junior doctor, it looks like it is potentially a recurrence of her depressive illness. You can see from her notes that she's had a suicide attempt when unwell in the last year. And you establish that there's been a number of stressful things happening in her life over the last few days to weeks, which is what's led to her being in hospital now. You don't think that she's fully considering the risks, and you think that her depression is affecting her ability to do so. And I wonder, on the back of what we've been talking about so far, what do people think is the relevance of that last section? So what does the fact that her depression might be that you think that she's got a recurrence of depressive illness and her depression is affecting her ability to do some thinking, what does that mean? And specifically in terms of capacity. So her capacity could be impaired. Yeah, exactly, Unica. So there is a mental or brain disorder that is potentially impacting on her capacity. And I wonder if your point specifically also relates to you don't think she's fully considering the risks, because which bit of capacity could you there say seems to be impaired? Yeah, exactly, Izzy. Thank you. So you're thinking that the weighing up is impaired. Maybe the understanding is impaired as well. So you could check that by, seeing if she can say back to you what the concerns are that you have. But it may be that it's the sort of weighing up of the pros and cons that you just don't think she's able to do right now. We know that depression affects somebody's thinking from a concentration perspective, from a decision-making perspective. So it's very reasonable to think that this could be happening for Miss Jones. So what are your options? And the information that is important to know is that you are a doctor who is at FY2 level or above, and you are on a psychiatric ward. And so what you can do at this point is, if she is actively trying to leave, then you can be thinking about using a Section 5.2. The reason that I made those points, that you are a doctor who is at least at FY2 level and that she is an inpatient on a psychiatric ward, is that you have to be an inpatient in a hospital for the Section 5.2 to be available to a doctor to use. And so this is what is difficult in the situation that you describe, Adetola, in that that person is an A&E. A&E is not classed as a ward, so you cannot use a Section 5.2 in A&E. And potentially as a junior doctor, again, it depends what level of junior doctor you are in assessing the person, but we'll come back to that question in time as well. A Section 5.2 is, again, colloquially known as a doctor's holding power. So it means that you can legally keep that person on the ward for 72 hours. Within that time, the idea is that that person is being reviewed by a senior clinician who is thinking about what the next steps in that person's treatment journey should be. If she is not actively trying to leave, so she's just saying, I don't want to be here, but okay, I'll stay. You don't necessarily need to be using the Section 5.2, because it does apply in those situations where somebody is trying to leave and you therefore need legal powers to be able to keep the person in the place where they are. So if they are not actively trying to leave and you're not actively restricting them from leaving, you may just have more time to be able to think with them about what the right treatment steps would be, and have more of a discussion. Again, that starts to get quite nuanced, particularly if they're saying, I don't want to be here and I want to leave, but perhaps because they're so depressed and so unwell, they can't actually get up to try and leave. Have those discussions with your senior if those are the types of situations that you're facing. Any questions on the 5.2? Feel free to send them along as they come, even if out of order, but I will carry on for now. So, as I say, the next step after a Section 5.2 should be that somebody senior is then coming to review that patient. So that might be the SPR, that might be the consultant. In some parts of the country, you might have sort of nurse practitioner, GP type people who are working and have training within, who have Section 12 training, so have approvals within the Mental Health Act. Most commonly in my practice, it would be the SPR, so the registrar doctor. You join in with them when they review, and you see that they also establish that Miss Jones has some delusions of guilt. So she feels worthless and guilty and responsible for bad things or bad events that have happened. They get some feedback from the nurses that she's really not been eating or drinking in the time that she's been here. She continues to not agree for admission, and the judgment is that she doesn't have capacity to make that decision. So the questions that I will address at this point is, when can a Section 2 be used, and what is a Section 2? I will share a quote, and this has come from the Mental Health Act review from a philosopher. So he was quoted within the Mental Health Act review. And I guess this tries to instill upon what a difficult decision it can be to use the Mental Health Act. and what a difficult decision it should be, and why the principles of least restrictive practice are most important. So I will just read it out. So sometimes compulsory admission to a place of safety for a short period of respite care, even where conditions are far from ideal, together with the short-term, even involuntary administration of some sedative medication, can be a way of returning an individual in such a state of extreme distress to a condition where they can make thoughtful decisions about their own lives. So this is just a brief quote to explain that we know that in some situations, it feels like we're caught between a rock and a hard place when we're trying to make a decision for a person. Sometimes it's very clear that the only option for somebody is admission to hospital, but sometimes it's less clear. And what the things that you're trying to weigh up as the clinician, and at this point I'm talking potentially about being a fairly senior clinician, but it is the person just in such a state of distress that we have to do these things that we know aren't ideal, but to try and get them back to a place where that distress is less and where they can be involved in the decision-making around their health. So a section 2 is a compulsory section, or a type of section that enables some compulsory treatment of a person. It is called an assessment section, but that assessment can also involve a trial of treatment. It's a section that lasts up to 28 days. And something that patients often ask me is, gosh, so I'm going to be in hospital for a whole month. The answer to which is no, not necessarily. Maybe yes, but maybe no. It is an up to, and that can be helpful to explain to someone. So again, it's something that I would want people to take away from this session. In terms of when it can be used, so generally, at least in London, the practice would be that it is a senior doctor who would use the section 2 on, and in a situation where somebody has a mental disorder of a nature or degree that warrants detention. And by nature, what we're talking about is that they have a specific psychiatric condition. That's what the nature bit, and degree is that there is severity. So it isn't, generally, you are not just saying that everyone who has some kind of past diagnosis of psychiatric illness can have a section used. The idea of degree is also important, so that they are experiencing a relapse or that there is some severity of that illness that warrants the detention. The principle that you're working off is that they need to be detained for a short time for assessment and possibly medical treatment. And there's a question of risk. So it's necessary for their own health or safety and for the protection of other people. And in this case, the way that you were able to make that assessment as the senior doctor is you've got feedback from the nursing team that she's not really eating. You've got feedback from your junior doctor that she's expressed thoughts of not wanting to be alive, and that there has been a past history of when she's been unwell, that there have been suicide attempts. So you've got some idea that there is a risk to her as a person. The way that I'll come to those. So the way that a section 12 is used is you will have a doctor who makes what's called the first recommendation for that section. Again, as I say, generally that will be a senior level doctor, often who's gone through the section 12 approval process. That isn't always necessary, but again, nuanced area, and it can depend on where you work in terms of what just local policies are. So for reasons of simplicity, we'll say that it is a senior doctor who has been through the section 12 approval process. Once that first recommendation is then sent to the AMP, so that's your allied health professional, the AMP then coordinates a mental health act assessment. So they bring along a section 12 approved doctor, and together they will assess that person. So they are independent, so they are not somebody who is working with the team that has made the first recommendation. Quite often they'll be completely external to the hospital trust, but that isn't necessarily necessary. They will read through the notes, they will speak to the person, they might speak to their relatives, and they will then make a decision on if that first recommendation is sort of an appropriate first recommendation, and if the best treatment option is for that person to have a period of admission under the Mental Health Act. If you ever work on wards where you hear about somebody having a first recommendation made and you're able to join the Mental Health Act assessment when it comes, it's really good, really good to do so, because then you get a very good understanding of how it is that AMPs and the Section 12 doctor work together, how they do the assessment. It's often a very good way of seeing a psychiatric assessment. So I would definitely recommend speaking to the AMP when they come onto the ward and seeing if they're happy for that to happen. They will always obviously ask the patient if they're happy for an observer to join as well. A couple of situations that you might hear about or that you might come across, and that will lead us into talking about the final section of the Mental Health Act that we'll talk about today. So that's a bit of a hint for anyone who's encountered the Mental Health Act. But what might you be thinking about? And this is potentially a few steps up from where people are working, but if you're the senior doctor, what might you be thinking if this is Ms. Jones's third admission this year with an established diagnosis of treatment-resistant depression? Or what might you have to do if she's still really quite unwell 3 weeks down the line? And again, we're talking legally rather than any particular clinical decisions that you have to make. And I've run out of water, so if my voice goes funny, I do apologize. So what I'm getting at here is we might be thinking about using Section 3 of the Mental Health Act. And this formally is, formally, probably not formally, more like colloquially again, known as a treatment section. But the reasons for why it's used is treatment. So it is a section that lasts for much longer than a Section 2. The situations in which it can be used is that the patient has a mental disorder, that they need to be detained for their own health or safety or for the protection of other people. There again will be a question of what is the nature of that mental disorder and what is the degree of it. And a key part is that treatment can't be given unless that person is detained in hospital and there is appropriate treatment available. So if you have to demonstrate that there is some kind of treatment available, and you have to demonstrate which hospital it is that treatment is available at. The things that make a Section 3 different from a Section 2, as I say, first of all, that it is longer. So it is, again, for a maximum of 6 months. That doesn't mean that it is a minimum or will always be 6 months. It may well be shorter. It may just be that you need an extra few weeks, or you predict that you need an extra few weeks from when the Section 2 will end. You still need legal powers to keep the person in hospital because they're not well enough to be able to be involved in or to be able to make that decision themselves. But so, as I say, it does not have to be 6 full months that the person stays in. The other key difference from a Section 2 is the involvement of the nearest relative. So they have to be consulted for a Section 3. So that means the person who is the legally defined nearest relative has to be spoken to. They can actually be the person who applies for a Section 3, but also importantly, what they can do is object if they think that the application is inappropriate. Now, the nearest relative is not the same as a next of kin. So again, something that is really important to take away from today. There is a legally defined list of a nearest relative. If you're interested, give it a Google so you can see how it goes. But it is not the same as a nominated next of kin that the patient has chosen. It is actually a legal list of who that person is. And if the person at the top of the list isn't someone that exists, for instance, like a marital partner, then it goes down to the next person on the list. Any questions on Section 3? In terms of the application process for it, it is, again, very similar to a Section 2. Yes, very good point, Adetola, and I will come to you. So very similar to a Section 2 in that, again, a first recommendation is made by one doctor, And then the AMP and the Section 12 doctor will come to review and assess the patient, and the AMP will then make a decision as to whether they will apply for Section 3 to be used. When contacting the nearest relative, are we also going to consider patient's confidentiality and consent? Yeah, absolutely. So it can be very tricky when somebody does not consent to information being shared with the relative, with the nearest relative. The question that you as the team, both the treating team but also with the AMP, will be considering is, what are the reasons that they're not consenting? Is it a reason of safety? That it's not uncommon for it to be that the legally defined nearest relative is somebody who, against whom there might be safeguarding concerns. Is it related to the person's mental disorder? So do they have, we would hope, so in order to use this as part of your decision, you would want to know that it is established diagnosis of, say, delusions against that relative. So you will absolutely be considering it. In terms of how you will use that to make the decision is so case specific that I won't say one way or another, but it's a conversation to be having with the team and most importantly with the AMP, because they are doing this every single day and they have heaps of experience of how to make that decision. You may get to a point where you are seeking some kind of legal advice from within the trust in order with how you're going to proceed, because these are really, really important issues around confidentiality and consent. So yes, absolutely considering it, and absolutely not just going, don't worry about it. Just call up the first phone number that you see on the list that applies to the legally defined nearest relative and just give them all the information without thinking about it. So very well raised. I'm going to come to talk about what are the issues with the Mental Health Act, but people, please do feel free to send in questions as we go. So I've lifted quotes directly from the independent review, and I've linked it here in case people want to read. Simon Wesley was the chair, and he writes really, really eloquently, really in a way that's very readable. It feels like almost like he's speaking to you, like it's quite emotional writing. So it's interesting to read. And he describes some of the problems with the current Mental Health Act as it is. So they believe that it's necessary to improve patients' and service users' ability to make decisions about their own care and treatment, and that this is essential in upholding dignity. And so one of the recommendations from the review is to have something called advanced choice documents, where people can say what treatment they would like to have if they became unwell and got to a point where they no longer had capacity. The recommendation that they've made from that review is that even if that treatment is not the ideal treatment or necessarily the sort of best evidence-based treatment, but it is available, clinicians will have to think really quite long and hard about going against the choices that are raised in an advanced choice document. All of these things are recommendations. They haven't yet come into law. They haven't come into updates. But this is just to give you an idea of the sorts of conversations that are happening when it comes to the Mental Health Act. One of the most troubling and difficult areas that they have considered, but that also we as clinicians are very aware of, is the fact that people from ethnic minority communities are far more likely to be subject to the compulsory powers under the Act, whether that's in hospital or in the community. And again, this is a reason for why the Mental Health Act was being reviewed, and they have some recommendations around the kinds of work that should be done to try and improve this, but also, again, just the thinking that clinicians should have. This point of the nearest relative is something that is quite contentious, and the feeling is that people should be able to choose their own nominated person rather than it being just a relative that is nominated legally, rather than necessarily that the person feels is the person that knows them best or the person that should be involved in legal decisions about them. They highlight that too often it is a crisis rather than a need that opens the door to psychiatric services. There wasn't sort of a very specific recommendation that I picked out to highlight what they thought should be done about this, but I thought it was important that they noticed it, because I think this is something that patients very often say to us. They say, no one seems interested in my deteriorating mental health. It's only when I get to the point of crisis that everyone suddenly comes running, starts to use the Mental Health Act. And again, the review notes that the aspiration that voluntary admission as the norm should be what we are aiming for. And that right now, the situation is that it is probably fairly unlikely in lots of parts of the country that somebody will go into a psychiatric hospital unless it's under a section of the Mental Health Act, because services are so strained and resources seem to be so low that it seems to be that's what's required. And they highlight in this review that they think that maybe there's something there to be looked at and changed. One point that the review considered was around people with learning disabilities, autism, or both, and that they considered this quite carefully, and they said that removing this from the Act right now is not the right thing to do, but that there's a lot of review to be done, so that the Mental Health Act, they recognise that the Mental Health Act is used inappropriately in people who are autistic or have learning disabilities to keep them in inappropriate care, as opposed to providing potentially appropriate care. The reason why they say that there aren't changes that they're actively recommending is that there are some situations in which it is necessary, and the nuance is such that they aren't able to make changes at this point. And again, I think a really important point to note is that they called on the government to invest in modernising the mental health estate. And this links to the quote that I showed before, which recognises that often the environment in which we are legally enforcing and compulsory detaining people in is not somewhere that we would ourselves want to be admitted to. There are some very good wards in terms of their physical environment, but I think it's realistic, and they note in this review that there are some wards where the environment is not good and it should be better, particularly because we are using legal powers to keep people there. There isn't an answer that I can offer to what the solution is, but it is something that, again, you should have in your mind if and when you are using the powers of the Mental Health Act and thinking about the least restrictive option. So is there any way that I can get this person home with their consent and safely, rather than bringing them into hospital, because I know that the environment isn't always perfect. I will end with some resources. So the one point actually that I haven't put on here is that charities like Mind and Rethink Mental Illness also have some very good and very legible information on the Mental Health Act. And obviously Mind the Bleep, I'm sure Izzy can weigh in on this, but we'll have resources as well. If you came to my last session, I talked about this podcast, Is Psychiatry Working, a BBC Radio 4. Again, they talk, it follows the journey of a person with psychosis through the Psychiatric Services system. And they talk about the Mental Health Act within that. It's not a podcast specifically about the Mental Health Act, but it still gives you a really nuanced and balanced understanding of the good things and the difficulties within psychiatric practice. And obviously I'd be remiss if I didn't mention the podcast that has brought me here to speak to you guys, and that's the Thinking Mind podcast. Lots of ranges of topics, conversations with experts, and again, trying to bring nuanced discussions around psychological, philosophical, psychiatric ideas. In the absence of other questions, let me come back to Adetola, to your question, and explain the kinds of thinking and the kinds of advice that you might get. So this is an issue of a patient in whom you think that there is a risk because they've come in with attempted suicide. They've been told that medically they're well, so there aren't any physical concerns to keep them in hospital. They're in A&E, so they're not admitted onto a ward, so you cannot use 5-2 powers. But they are insisting on going home. The way to think about this case and involving senior people in the decision-making is, what do you already know about this person? With fingers crossed, you know that you've got some kind of past psychiatric history on them. In some situations, you won't. But what do you know about them? Do they have any known mental disorders, any psychiatric conditions? What can you get from them by talking to them? And I guess really that's step one, is just go and talk to them, try and figure out what it is that's going on that is making them want to leave. Sometimes you can establish something really straightforward, that A&E is just a really unpleasant environment. They feel really distressed. They feel really upset. They feel really unwell. Sometimes people just need that to be heard and to be understood, and for someone to say, like, yes, I know this is not the place where you want to be. What can we do to make it even a little bit better? Can we find a slightly quieter space? Can we get you something that will help you feel comfortable, like a phone charger? Is there anyone who can come to be here with you? Can we get you even, some earplugs, or be as creative as it might be necessary to be? Sometimes it is something as simple and environmental as that. Often it isn't. But often actually it's a combination of things that is making somebody not want to stay in the hospital. So addressing each little thing in turn might get you closer to be able to engage them in staying there. Because the bottom line is there isn't a straightforward legal power that will enable you to stay, that will enable you to keep them in hospital. If there is a clear concern around risk, then some people will talk about things like being able to use common law. The issue with common law is that it's meant to be used in sort of quite short emergent situations. And I have neither the, expertise nor the time to talk about it in detail, but that's something that can be sometimes called upon. But as we discussed in our Section 12 training, it's tricky territory. So involve a senior person. You potentially could use the Mental Capacity Act if you feel like they don't have capacity. But in a situation where they potentially do have capacity, it becomes tricky. So the simplest answer is go to speak to the patient, see if you can establish a relationship and a rapport with them, and see if you can bring them on board with the need to stay for a review and an assessment. As part of that conversation, you will inevitably get some information about, just how dangerous it is for them to be going, just how unwell they are, and be able to use that information to then make a decision about what the best way to go is. But it's tricky, and it's really very dependent on what the case is. I appreciate that will not have completely answered your question, but feel free to follow up if you've got further questions, and if there's any other questions that people have as well. I think there is a feedback link that is being sent. Please do fill it in, because constructive criticism is really helpful. We've got more of these sessions coming up, and I've tried to implement some of the feedback from the previous sessions. From my previous session into this one. So it definitely makes a difference. If there's anything that you liked or you think that more should be done of as well, that's really useful. But I will pause and let Izzy talk. And obviously if there's more questions, then I can come back in.
Yeah, I just wanted to say that the feedback forms on the chat, we've got coming up in the psychiatry series, the leadership and team dynamic session, which will be on the 3rd. That will be generally applicable to just, I think, life in any training sphere within the hospital setting for kind of multiple members of the MDT. So everyone is welcome for that session, and it should be more of a looking at maintaining your own well-being and processing like the inevitabilities of the job, whether that be like colleague to colleague or patient colleague situations. And then we've also got on the 17th of July, so these are both Monday days, the 3rd and the 17th. The 17th will be with Rebecca, who's also from the podcast, and that will be on psychotropic medications. So again, a very useful topic. And all of the recordings are on Med.all at the moment. This one will be available shortly after. So feel free to watch them back or on demand at a later date. also in the kind of psychiatry page process, there's going to be another co-lead who will probably announce soon, but they will also help with bringing in some of the kind of pediatric topics, so CAMS, pediatric presentations of mental health disorders. So I think that would be a really good way of us to kind of expand what we're already offering. So we'll definitely do some collaboration with the peds team. So if there's anything else you want in terms of future sessions and webinars, we'll definitely be looking into that as well. So just pop that all on the feedback. Yeah. But otherwise, I hope everyone's had a really good time. And thank you so much, Anya, as always. This has been a really good session. The Mental Health Act is definitely something that I need constant refreshing of. And I'll definitely need it in my A&E job as well coming up. So thank you very much.
Thank you, and thanks everyone so much for coming and for pitching in with questions and comments. It's been a pleasure, and thanks Izzy for organising, because it's really great and amazing to have this series. So nice one.
Cool. Have a good evening.
Bye everyone. Thank you.